Thank you so much. First of all, I would like to thank the organizers for inviting me here on this very special day. And I'm delighted to talk about one of my favorite subjects, which is quality of life of patients. I'm a pediatrician in the field of inborn errors of metabolism, which are all rare. And I think we need to pay more attention to quality of life of our patients. I will talk to you why we need to look at quality of life, how and in whom we should measure quality of life. Why? Quality of life is the essential outcome of any treatment. It's the ultimate outcome. We do not treat our patients to have a certain biochemical level or not even to walk a certain amount of steps on a 6-minute walk test. We treat them to have their best possible quality of life. And any treatment that improves biochemical assessments or minor things that are not experienced as improvements by the patients are not effective. Quality of life is the ultimate outcome of any treatment. And it has increasing relevance with increasing survival. In my field of inborn errors of metabolism, we now see adults with diseases that we never saw before because patients passed away before reaching adulthood. Now, with better care, more structured care, more knowledge, they are reaching adulthood, but they should be able to have a life of good quality, a life that's for them really worth living. And it's increasingly relevant, and I think that makes the professionals responsible for trying to ensure the best quality of life in their patients. And for that, we need insight in the quality of life of the patients. And I think professionals have usually a mind of their own, and we think we know, and we don't. If you want to know about the quality of life of a patient, you have to ask the patient. Especially in rare diseases, I think it's hard. As a professional, you see patients, and you can try and think and estimate what it's like to be a patient and what bothers you the most about your disease. But there's proof that we don't know. Quality of life is a very personal and subjective thing. Some people enjoy doing crafts. Some people enjoy having more adventurous lifestyles. But in the end, it's the patient's own perspective, and only the patient can tell you what matters most for their quality of life and how they're most affected by the disease. But it should be measurable, because if you want to do something about it, if you want to have an overview of a patient group quality of life, and you want to be able to improve, you have to measure this very subjective thing. Therefore, we have a concept that's used in quality of life research that tries to catch that, and it's health-related quality of life, and it is an individual's satisfaction or happiness with those domains of life that affect health or are affected by their health. And you have to ask the patient, really. You can try to catch it by giving patients standardized questionnaires and collecting all their answers and looking at the outcomes of that. And you will have unexpected findings. One of the most striking examples, I think, is studies in doctors and patients. They asked doctors to rate the quality of life of the patients. They asked the patients. And they did that in a very simple situation. They asked dental surgeons about the effects on quality of life of the patients after removing a molar, removing a tooth. Very simple, takes a few days. After that, the patient doesn't have complaints anymore. They asked the patients, they asked the professionals, and they asked about things like sleep, eating, pain. And on 4 of the 7 parameters that they inquired about, there was a significant difference of estimation of quality of life between the patients and the professionals. Well, if we can't predict what bothers the patients the most about the removal of a molar, how can we have insight in more complex diseases? There are several ways to measure quality of life, and I think the quality of life research has really improved in the last 10 to 20 years. You have to have validated questionnaires. They have to be validated in language and culture. You cannot just translate any questionnaire and send them out. You have to make sure that every time a patient completes the questionnaire, they experience the same question, the same thing is asked, and they give an answer to the same concept. You have to take culture into account. What's very important in some cultures is not so relevant in other cultures. You have to have age-specific questionnaires. In children, usually we can put questionnaires to children from 6 age and up. Usually it's 6 or 8 to 12, 12 to 16 or 18, and then adults. And then in parallel, you can ask proxy questionnaires. So you ask the parents about their views of the quality of life of their children. And then you can also take in the children until age 6, because the parents can have an estimation of how the children are doing. Also, in patients who are not able to complete the questionnaires themselves, children or adults, the parents or the caretakers can complete proxy questionnaires to give you at least some insight in how the patients are experiencing their life and what's bothering them most. There's 3 types of questionnaires that we use. It's generic questionnaires. Generic questionnaires very generally ask you about life, about work, about being able to move, about sleep, about exercise, about fatigue, about work, about general concepts. You can ask them to the general population, and you have a very nice control group of a country to see what's the general quality of life in that country. Then you can put them to patient groups. You can compare the patient group to the general population, but you can also compare patient group to other patient groups and see if there's any difference. It might be very general, and sometimes people find it very tedious to complete because they don't always feel it concerns them specifically. Then you have general questionnaires aimed at the chronically ill that are much more focused on worries about your illness, about difficulties going for hospital visit, about the time that your treatment takes, things like that. And there you cannot compare to the general population, but you can compare different patient groups and see what the impact of a specific disease is. And then, but rarely in rare diseases, there are disease-specific questionnaires which help to find out about the specific issues that are relevant for specific patient groups. I will show you some of the examples of what we did in our patient groups, which are all rare diseases. And you can do these studies very well in rare diseases. Many of our studies were in 30 patients, maybe 50 patients, no comparison to the thousands of patients that are usually included in studies for diabetes and high blood pressure and things like that. But still, it's very clear, and we have very great and clear results. One of the diseases we looked at is galactosemia. It's rare. 1 in 45,000 people has galactosemia, and they cannot metabolize galactose, which is milk sugar. So any baby with galactosemia who drinks breast milk or infant formula gets very sick in the first week of life. And they might die if they don't get treated in time. And many countries have included it in the newborn screening program. As soon as you start with a galactose-restricted diet, a diet without milk or milk-containing produce, they recover very quickly. But patients have to keep the diet lifelong, and some of the patients have difficulties with cognition, with moving, with speech, and they may have social problems. In this group, the first time, I think the group was 45 patients, we looked at quality of life with generic, very general questionnaires, and we saw that their quality of life was severely affected. And then it's hard to decide, is it because of the strict diet, which causes social isolation? Is it because of the development and social problems? Then we looked also at PKU. It's probably the best known inborn error of metabolism, included in pretty much every newborn screening program. It's a protein breakdown disorder. If you start patients on diet in the first 3-4 weeks of life, they have a fully normal outcome and a fully normal development. But they have an extremely strict diet. They can hardly eat any natural protein, and they eat lots of specific products that are developed for them that are not very good tasting. It's a very hard diet, but they have a very good development afterward. And in them, we saw that their quality of life was fully normal, in spite of a very strict diet and awful foods they had to take, they had a fully normal quality of life. And that means that probably the diet might also in galactosemia not be the most impacting factor. And indeed, we saw that the developmental problems and the social problems were the most impacting factor in galactosemia. And at that time, you were able to work with that. And what we did was we included it in our future studies, and we included it in the international guideline to take more notice of the social difficulties, of the cognitive difficulties, and offer more support in that area. And while we cannot treat it, we cannot prevent the cognitive difficulties, we can deliver timely support and pay attention to it. Then, in PKU, a new treatment became available. It was called sapropterin, and it is chaperone therapy. The enzyme in PKU is deficient, and sapropterin does stabilize the enzyme, which made that patients could eat more natural protein. Some patients could go totally off diet. The majority didn't, but they could eat much more natural protein, which really relaxed their diet and made life easier, we thought. It's effective in about 30% of patients. And we performed a prospective study of their health-related quality of life while introducing this treatment. And we did this without the industry. You said we want to look at our own patients. We don't want any, because there's always different gain in industry. We want to to study it ourselves. We tested the patients with generic and disease-specific questionnaires before we tested for responsivity to this treatment. So everyone was excited, everyone had the same expectations. I hope I will be responsive to this treatment. Then they went through this responsiveness testing. Approximately 30% was responsive, could relax the diet. And then after 1 year, we tested their quality of life again. And we waited 1 year because the ones who were not responsive, it was a severe disappointment, and it does affect your quality of life. But it fades with time. So after a year, we tested again, and we found no improvement. That was odd, because patients were telling us, the patients who were on the medication said, my life is easier. I can go out with a friend, just have dinner somewhere. I can eat some more protein. I don't have to worry about my diet all the time. My levels of my biochemical levels are more in balance, doing much better. But then again, we couldn't find it, but their health-related quality of life was already fully normal before, and specific issues that were important to them were not addressed in these general questionnaires. So it's not so surprising that we could not demonstrate it, but that may hamper evaluation of new therapies, that you cannot demonstrate it. Then one of the companies involved in new therapies for PKU became involved. And he said, well, let's make a PKU-specific questionnaire. And that was a very interesting journey. It took 3 years, almost 4, I think, selecting the relevant issues for these patients, validating the issues in 7 countries, validating the questions in 7 languages, development of a scoring tool, and then we did a major study including like 350 patients, still not a lot, worldwide concept, but for a rare disease it was a lot, to see if the questionnaire worked, and it really worked. We saw that it elucidated the most important issues, and we could see clear differences between patients on different types of treatments, patients with different severities of illness, and that was very clear. Wonderful. The point is that it's very hard in rare diseases. You need a lot of funding, it's a lot of time, a lot of work, and you have to maintain the questionnaire. And the sad thing is that once the new treatment was on the market and the company did not benefit from it anymore, they stopped maintaining it, and the questionnaire is no longer available in spite of 4 years of work of many professionals and patients involved. It's a struggle, and especially for rare diseases, it's hard. But we saw that it was very relevant to have a questionnaire like that. What can be helpful in the next years is the PROMISE system that is being developed. It is a system looking at generic patient-reported outcomes. The PROMISE comes from Patient-Reported Outcome Measurement Information System. And what it does do, it has validated questionnaires on specific items, and you can pick and choose the items that are most relevant for one specific disease. You can pick upper body function, you can pick lower body function, you can pick fatigue, pain, and you can compose your own questionnaire and make it like that more disease specific. You can compare different patient groups on the same questionnaires because they can be used in different patient groups. You have computerized adaptive tests, so if the first question of a series is not relevant for you, you don't have to do 7 more boring questions that do not pertain to you. And it includes the most relevant aspects. And I shared these slides from one of my colleagues who is very much in the development of the PROMIS system, Lotte Haverman from the Amsterdam UMC. And you can see there's different scores on physical health, pain, fatigue, sedentary behavior, mental health, social health, and you can compose your own questionnaire and then compare it to control groups in different countries. I think this is probably the future of health-related quality of life research. Who should we measure it in? Well, of course, in the patients. And I've been talking a little bit about our own research. I know that companies use it in the evaluation of new drugs. I'm on the Dutch Medicine Evaluation Board. I see a lot of it, and many times I'm not so happy about the way it is used because they might not always pick the right skills, the right questionnaires, and I think there's a lot to improve in that. But beside patients, we also have parents and siblings. And we can use it in research, but we can also use it in clinic, because what's more important in clinic than asking, how are you doing? How is your quality of life? What is your most relevant issue, and what can we do to help you with that? In our clinic, we have the CLIC system, where it's a database, it's a web-accessible system where patients, before they come to the clinic, they complete quality of life questionnaires. Results are generated, and when the patient comes in the clinic, we can discuss those. It's extremely helpful, and at the time it started, professionals were going like, well, my clinic is so busy, so full, I don't have time for that. It just takes a lot of time, I don't think I want to do that. But research demonstrated it truly does improve outcomes of patients. You have a different conversation with patients. And interestingly, it does not increase duration consultation because it's so much more focused. And what you get here, like here, you get little charts with scores going up and down. And you can say, what's the matter? Your score is going down. Has anything changed? Then again, it's a luxury in my hospital because we have a group that's very involved in that. It's not possible everywhere. But it's possible to be aware of the quality of life of the patients and just ask them. In our international galactosemia guideline, we did not give questionnaires to the patients. You can, of course. You can give them paper questionnaires, you can have them online questionnaires. But the main thing is be aware. Ask them about it and ask them about the most relevant issues. Note it, and next time ask them again and see if there's any change. Just awareness is very easy and feasible. But then it's not only the quality of life of the patients that's affected if you have a severely ill child, also the quality of life of the patients in emotional situations, work situations, financial situations, social situations. And it's relevant to study that as well and see where you can assist. And in research of the quality of life of parents, we saw a lot of items that can be addressed and that we can support them with. Some of the most important determinants are diseases requiring a strict diet. Losing or having emotional support makes an incredible difference for the quality of life of the patients. Loss of friendship. Probably anyone having a new child with a severe disease has experienced losing friends. Gaining some other friends, I hope, as well. But losing friends is main indicator. Anxiety, what will the future bring? And anxiety and uncertainness about the future is main impact, but also coping strategies. And some of these things we can help parents with, so be aware of them. And then siblings. Well, we might want to talk to you, and see where it brought you. But it's hard sometimes to have a sibling with a chronic disease because your parents are worried, occupied, you're worried. It does impact your life. There's very little research yet in siblings of someone with a rare disease. But it's important, and we should at least ask about it, and I think much more research is needed. So I think, especially on this Rare Disease Day, quality of life, it should be the ultimate outcome of treatment, and we should research it in patients, in clinic, but also in research settings, and we should look at parents and siblings. And I would like to thank all the patients and other professionals participating in our studies on health-related quality of life research. Thank you so much for your attention.
Thank you, Annet. Do we have questions for Annet? You can just raise your hand, võib käe püsti tõsta, kui on küsimusi Annetile. Julgelt küsida. Yeah, on. Vanessa has a question. We can give you a microphone.
Yeah, thanks. It's a super important topic, and I agree also that siblings have more to say in that research, so I'm happy to catch up with you and maybe do something around there. I wanted to share that to what concerns congenital disorders of glycosylation, the research focus on health-related quality of life was led by our group. And this was because we listened carefully to the community, and we realized that this was a topic considered very important, not only for families, but also for our clinicians and researchers. And what I observe is in diseases like CDG, where I have to say, we only have like one company a little bit interested in CDG, so it's very hard. What can we do to boost more studies around this topic for those diseases that are orphans among the orphans? I don't know if you can share some.
I think it's not so hard. It's not also, they're not expensive studies. The questionnaires are there, especially if it's academic research and not company research. Usually the questionnaires are available free. It takes some time to professionals, but you can do it on paper, you can do it online. You need experienced psychologists who can do the analysis and discuss it, but it's not so hard. And I think if you have a group of patients who together say, we would like our quality of life to be registered, and you already have the group of patients, and you go to the professionals, it's for them very easy and effective to send out the questionnaires and have everyone complete it. The participation, I think, in our studies is about 65 to 70%, which is higher than most questionnaire studies. But still, I think for patients with rare diseases, it should be above 90% because you want to have your voice. But if you organize and go to the professionals or go to a center of expertise and say, we would like to have our quality of life measured, it's not so hard.
Thank you.
Anyone else? Do we have more questions? Kas meil on veel küsimusi? On. Palun.
Thank you very much for your interesting presentation. I have a question regarding your work in clinic. If a patient is clicking the answers for questions before going to a doctor, and if a doctor is seeing that, today the results are really bad, is it organized immediately the support by psychologist on the same day or on the same week for this family or patient?
Maybe not the same day, maybe not the same week, but we pick up and see what's necessary, if there is indeed psychological support necessary or a physical therapist or extra care by the dietitian, and we organize it within the next few weeks. But it's a luxury. I realize that's not available everywhere.
We have a question from Slido as well. What is the next step? Could the results of the questionnaires be implemented on the government level health regulations?
Is the question, should they be obligatory? Is that the question, or is it how can we use it to
Could
bring
the
us further?
results of these questionnaires be implemented on the government level?
Well, I think it's important that if there's, especially for new treatments, if there's a new treatment available that clearly demonstrates an improved quality of life, it's a very strong argument for the government to pay for it, I think. And I think I'm not always happy by the quality of life studies that I see. Sometimes companies, it's an obligatory thing, and that's what it looks like, and they could do better. And if you have a clear increase in quality of life, I think that should be one of the most important reasons to pay for a treatment.
We can have one more question before we move on. Kui on küsimusi veel, siis ühe jõuame võtta. Tundub, et me saame edasi liikuda. Annet, thank you so much.
You're very welcome.
Yeah, a round of applause, loomulikult.